Deep inside the human vascular system, mast cells and the liver naturally produce a rapid-acting anticoagulant. In critical care, clinicians harness this molecule, heparin, to aggressively intervene in clot formation. There is a widespread clinical misconception about what this drug actually does. Heparin is not a thrombolytic. It does not dissolve existing clots. This diagram illustrates the actual mechanism. On the left, an untreated thrombus actively expands. On the right, heparin has intervened to halt the propagation and growth of the existing mass. Once that growth is arrested, the drug's role is complete. The body's own natural fibrinolytic system is then left to break down the static mass over time. Understanding heparin requires a shift in perspective. The clinical focus must move away from the destruction of clots and toward the precise management of the body's internal clotting speed. This mechanical intervention is required for critical conditions: deep vein thrombosis, pulmonary embolism, myocardial infarction, and atrial fibrillation. In these scenarios, the clinician must balance a life-saving cardiovascular intervention against the constant risk of hemorrhage. The monitoring protocols required for heparin represent the physical consequences of its molecular mechanism, rather than arbitrary hospital policy. For healthcare professionals under pressure, rote memorization is fragile. True clinical safety comes from deducing bedside actions directly from pharmacological first principles. To understand the rules, we must examine the coagulation cascade, a sequential biological chain reaction designed to stop bleeding. This flowchart identifies two critical nodes near the end of the sequence, factor 10A and factor 2A, or thrombin. Under normal conditions, thrombin converts fibrinogen into fibrin. That fibrin provides the structural mesh required to hold a clot together. When heparin enters the bloodstream, it binds to a naturally occurring protein called antithrombin 3. This heparin antithrombin 3 complex neutralizes both factor XA and thrombin, inserting a chemical block directly into the flowchart. This block halts the conversion of fibrinogen to fibrin, starving the existing clot of the structural mesh it needs to grow. Because heparin acts at the final stage of this cascade, its effect on clotting capability is massive and immediate. This potency necessitates extreme precision in dosing. Because heparin changes the speed of clot formation, clinicians must measure that speed in real time. For unfractionated heparin, the mandatory monitoring standard is the activated partial thromboplastin time, or APTT. This graph maps the timing of the patient's blood. For a healthy patient, the baseline normal APTT range typically sits between 25 and 35 seconds. The clinical goal is the therapeutic window, where the patient's clotting time is deliberately delayed to exactly 1.5 to 2.5 times their normal baseline. This chart illustrates a patient's data line entering the therapeutic window. Beyond this upper limit, the probability of catastrophic hemorrhage increases sharply. This requirement for continuous monitoring is specific to unfractionated heparin. The protocol changes with low molecular weight heparin, such as enoxaparin. Low molecular weight heparin provides a more predictable response and rarely requires routine APTT monitoring. Instead, clinicians check anti-A levels in complex cases. Administering unfractionated heparin requires holding a patient safely at a point of controlled anticoagulation, guided by the mathematics of the APTT curve. The physics of the drug's mechanism also dictate how it must be administered into the body. The intravenous route provides an immediate systemic effect, but requires an electronic infusion pump to prevent dosing errors. The subcutaneous route is used for slower, sustained effects. Nursing protocols mandate the rotation of injection sites and prohibit massaging the tissue after the dose. There is one non-negotiable rule: heparin must never be given intramuscularly. Muscle tissue is highly vascular. Combining that blood supply with a needle puncture and rapid chemical anticoagulation results in a severe pooling hematoma. The strict no IM and no massage rules exist as physical necessities to prevent tissue destruction and internal bleeding. Managing the therapeutic window requires a systematic checklist divided into distinct phases. Before administration, nurses verify baseline APTT, review bleeding history, and screen for contraindications like recent brain surgery or uncontrolled hypertension. Clinicians must also check baseline platelet counts before initiating therapy to establish a point of comparison. After administration, nurses monitor for systemic bleeding, specifically assessing for bleeding gums, hematuria, and melena. Staff must also remain vigilant for a serious systemic complication, heparin-induced thrombocytopenia, or HIT. In HIT, a life-threatening immune reaction occurs where the body destroys its own platelets while simultaneously generating new, dangerous clots. The nurse serves as the final check in the system, correlating abstract APTT values with the physical reality of the patient's bleeding risks. Heparin is typically utilized as an acute bridge to transition patients to long-term oral therapy, where the long-term maintenance counterpart is the drug warfarin. This matrix shows the differences. Heparin acts immediately through IV or subcutaneous routes, while warfarin is oral with a slow onset. Heparin is monitored via APTT, but warfarin requires PT and INR checks. Heparin is safe during pregnancy, whereas warfarin is strictly contraindicated. Modern clinical pathways use these overlapping therapies because their differing mechanical timelines allow a seamless transition from acute crisis management to chronic care. If heparin levels dangerously exceed the therapeutic window and active bleeding begins, an emergency protocol is required. The cascade block is reversed using the chemical antidote protamine sulfate. Administered via slow IV, protamine sulfate binds to and neutralizes heparin to arrest the bleeding. The safe use of heparin is entirely defined by the rigorous application of pharmacological principles at the bedside. Clinical success depends on connecting the microscopic mechanics of the coagulation cascade to hypervigilant monitoring and flawless bedside execution.